Welcome to Professor Sutton from Imperial College London, and to Professor Boon Lim, Clinical Lead for the Imperial Syncope Unit at Hammersmith Hospital, both members of STAR's Medical Advisory Committee. Thank you for joining and for being available for patients.
Good morning, Trudie. Thank you for having us.
Good morning.
Good morning.
Good morning. So I have some general questions to begin with. I would like to aim the first question to Professor Sutton. What is syncope? Why do people faint? And what are the main causes? Is it the heart, blood pressure, dehydration? There are a lot of questions in that first question.
Yeah, you probably have to ask the second and the third again, but let us start with syncope. Now, syncope is a symptom. And symptom means something that the patient reports when seeing the doctor. So it's not a diagnosis, but it requires a diagnosis. Syncope is a transient loss of consciousness, which means blackout, faint, that sort of thing. So what happens in syncope is a loss of consciousness. It's nearly always less than 1 minute and maybe only a few seconds. It typically has a warning for the patient, but on the first attack, patient reasonably can't understand what's going on and doesn't pay enough attention to it. Older patients may not have warning. The patient is unconscious, usually pale, falls to the ground because muscle tone is lost, there's no way of keeping upright. Or if sitting, may fall onto a table, that sort of thing. And it lasts a short time. Recovery is quick, normally. Only a few patients take longer to recover than a few minutes. And so this is syncope. So what causes syncope? Well, the commonest cause is the so-called simple faint. But as we're often reminded by you, Trudie, there's no such thing as a simple faint, because faints always have to be diagnosed. And so the patient experiences loss of consciousness, which may be reported as blackout or faint. The commonest cause is that simple faint, but there are many other causes. The most common next in line is actually caused by doctors because they reduce the blood pressure too much in patients who have high blood pressure. Then follows the heart. And the heart causes loss of consciousness in two groups. One, more common, is a rhythm disturbance of the heart. And that can be too fast or too slow. And secondly is structural heart disease, which I think is, the term is obvious, but it doesn't translate into something that a patient can necessarily understand. But if the outlet valve, the aortic valve of the heart, isn't too narrow, this can be associated with syncope. Likewise, if there's a big blood clot coming from the veins of the body through the right heart into the lungs, blocking the circulation or partially blocking it, then a faint can occur. So these are two examples of structural heart disease. There are rare causes due to neurological conditions, which fall into the low blood pressure category, but they really are rare. You remind me of the third question, Trudie.
Whether it was heart, blood pressure, or dehydration that causes syncope.
Oh, let's go back to the faint, because what makes a patient faint? First is they have a tendency to do so, but they may not know this. And second is a trigger. Now, that trigger might be prolonged standing, so gravity has worked hard on the circulation and there's too much blood in the lower part of the body and not enough in the central part that goes to also to the brain. Second, or an exaggerating factor, could be dehydration, which, if there's not enough water in the blood is more concentrated, as it were, and the blood volume is down, central blood volume is down, so the blood to the brain is less. These are two triggers. Sometimes they work together. There are many other triggers, very dramatic ones like the sight of blood. Well, this is working entirely in the brain. The blood is seen, and that creates the trigger that results in loss of consciousness.
Thank you. Professor Lim, what is the difference between presyncope and syncope?
Well, Trudie, syncope, as Richard explained, is a loss of consciousness. Now, presyncope is the state that most patients feel typically before they lose consciousness. So the word pre means before, and it indicates before syncope. Now, when assessing a patient or when assessing oneself, one of the key safety features or the key safety stratification tools we have as doctors in ascertaining whether syncope needs urgent investigation or not is actually the duration of presyncope. Because the more presyncope symptoms you have, the more lightheaded, dizzy, and potentially other symptoms you have before passing out, the more likely it is you will be able to get yourself into a position of safety before blacking out. So I'll give you an example. It's a very different risk if you see a patient who has walked down, say, the kitchen or standing cutting vegetables at the kitchen, and the next memory is waking up on the floor having broken their nose and smashed their teeth. That is a very, very short or no presyncopal warning symptoms. And that kind of syncope needs to be taken very seriously and investigated very urgently. This is in contrast, for example, to the patient on the train in a crowded environment, standing for a long time to get to work, feeling lightheaded, dizzy, nauseous, perhaps with palpitations and chest pain, and that all those symptoms can be considered pre-syncopal symptoms that are symptoms to do with feeling unwell before you faint. So that's the distinction between pre-syncope and syncope. And patients should be taught to recognize what are the pre-syncopal symptoms that could be the warning symptoms prior to impending syncope, because then they can take the adequate evasive action and counter pressure maneuvers to avoid syncope, or at least draw attention to people to help them to avoid injury. So that's the distinction between pre-syncope and syncope.
Thank you. That will help a lot of people.
Should we explain what counter pressure maneuvers are? Would you like to do that later?
No, let's do it now. I'm sure a lot of people will suddenly be thinking, what are the counter maneuvers?
Sure. Can I bring in a graphic, Trudie, which may be very helpful to explain this? I'm going to share my screen now. And what I would like to share with the audience is this. So this is a graphic, for example, to illustrate very clearly what happens when you're initially standing up from a seated position. So first of all, let me clarify that we have a circulating volume. So we have blood, this red stuff in the brain, in the heart, in the vessels here of the upper limbs, the lower limbs, and in the gut itself. So these are the vessels which are full of blood. And let's say, for argument's sake, we have 5 liters. Now, it may be less than that in some individuals, but for argument's sake, 5 liters, maintaining a decent blood pressure, i.e. in green. Now, when you first stand up, what happens is that the blood can fall from the brain and from the heart with gravity and start to fill these lower limbs. So these lower limbs are now expanding with blood. And if you imagine standing for slightly longer, the heart is now getting fairly empty, as is the brain, these blood vessels are maximally dilated. Sometimes the gut can also be dilated, which can explain some symptoms of presyncope or nausea or dizziness after a large meal. And also the skin, which is your largest organ, can be starting to fill with blood when you flush red. And this can occur also, for example, with alcohol, which is a trigger factor for vasodilatation. And in this situation, the blood pressure is falling very abruptly. So one of the things that this triggers is a reflex. And this reflex is a reflex here in your brain that triggers a warning signal. This warning signal creates an adrenaline surge or a fight or flight response. And this fight or flight response causes vasoconstriction. And what this means is that adrenaline acts on these vessels to squeeze it tight. And the net effect is that we squeeze the blood back up into the heart, filling it back and filling the brain. So we have less of this presyncope effect and we avoid syncope. Now, what Richard's talking about with counter pressure maneuvers is when we are able to physically, at this stage, for example, when we're minimally dropping in our blood pressure, where at this stage, where we have the ability to actually squeeze our muscles. And this external muscles that we can squeeze here, for example, in our large quadriceps, as well as in our calves, will send the blood back up into the heart, filling the heart. Some of us also can squeeze our abdominal pecs, those of us who have pecs, and squeeze our biceps and grit our teeth. And all this serves to push blood back up. One of the other things that this diagram will illustrate is if you were to wear compression stockings, and some of you would have been advised by your doctors to wear external compression, that essentially looks like this. Tights, essentially grade 2 or 3 pressure tights. And this, you can imagine, provides a degree of external compression to send the blood back up. Some of you have been taught to wear abdominal girdles or corsets. Again, you can squeeze the gut and push the blood back up. So the idea of a counter pressure maneuver is explained, or the mechanism of action can be explained, because you are merely pushing the blood back up to the heart and filling the heart, and therefore allowing the cardiac output to increase. So I'll stop sharing my screen and give the floor back to you, Trudie.
Thank you. Professor Sutton, could you explain the difference between reflex syncope and vasovagal syncope?
Reflex syncope is a generic term, and it includes vasovagal syncope and so-called carotid sinus syndrome. And so reflex syncope is just a general term. Vasovagal syncope is the British medical term for the faint. And it is widely adopted through the world, although in the US, they call it neurally mediated syncope quite often. Unfortunately, there are a lot of terms in this field which are not helping to clarify what we're talking about. So I don't use neurally mediated syncope, I use vasovagal syncope because it says what it means. Vaso is of the blood vessels, as you just heard from Boon. And vagal is one of the main nerves from the brain to control things in the body. And it does that unconsciously. We don't know it's working, but it goes to the lungs, the heart, and the intestines. And to the heart, the vagus nerve slows the heart, which under the circumstances that Boon has just described is counterproductive, really, and is the final straw in the camel's back that makes one lose consciousness certainly in young people and occasionally in older people.